You watch their face, but the truth is in their posture. You think your medical degree commands respect, but it doesn't.
That's intense, Dr. Rivera, but you're right. I spent years mastering pharmacology and diagnostics, but I can lose a patient's trust in the first 10 seconds.
Because competence is judged before you ever order a test. It's judged by the words you choose. Most professionals speak English. Few speak trust.
And that's what kills me. I see brilliant colleagues who make tiny phrasing errors that sound cold or dismissive. They think they're being efficient. The patient thinks they don't care.
Today, we strip away the errors. We fix the broken signals. Welcome to the English Lab. I'm Dr. Alina Rivera, and I'm here with Marcus. Today, we're doing a deep dive into what we call the mistake fixer.
That's right. We're looking at specific phrases used at reception and in the exam room that can actually destroy rapport, and we're swapping them for phrases that build trust.
Because medicine is ultimately a transaction of trust, Marcus. If the patient doesn't trust you, they won't follow your instructions. And if they don't follow your instructions, you've failed, regardless of how accurate your diagnosis is.
Exactly. And for many of our listeners, especially those for whom English is a second language, it's easy to get so focused on efficiency that you become blunt. Communication starts to feel like a secondary skill compared to the clinical work.
But the clinical work is useless if it can't be communicated effectively. We're looking at two critical battlegrounds today: the reception desk and the exam room.
Here's how this works. I'm going to play the role of the busy, stressed medical professional making those common mistakes, what we call direct translation English. Dr. Rivera, you'll be providing the fix.
And remember, we're not just fixing grammar, we're fixing the psychological impact of your language. You want to be respected, then you must speak like someone who deserves it.
And before we dive in, for those of you watching or listening, we've put together a free resource with all the vocabulary and phrases we're discussing today. You can find a link in the comments or description below.
Now let's get into it. The reception area isn't just a waiting room. It's the first line of defense. It's where anxiety either escalates or dissolves. If the interaction here is chaotic, the patient enters the exam room already defensive.
Okay, scenario one. I'm at the front desk. It's busy. A patient walks up. I look up from my computer and say, "Do you have an appointment?" It's grammatically correct. It's direct. What's the problem?
It's an interrogation. It implies they don't belong there unless they can prove otherwise. It sounds like a bouncer at a club, not a healthcare provider. It sets a tone of bureaucracy, not care.
So how do we soften that without wasting time?
Here's the fix. You look them in the eye and say, "Hi there, are we seeing you today?"
Are we seeing you? That's subtle but powerful.
Notice the shift. "Are we seeing you" implies a team. It implies you're expecting them. It's warm yet professional. It changes the dynamic from you versus me to us.
I like that. Okay, next one. We need their insurance card and ID. Usually people just say, "Give me your ID," or "I need your card."
That's a command. You're taking something from them. It triggers subtle resistance, even if they comply.
So the fix?
Use modal verbs. Could I please have your ID and insurance card? Could I? May I? These aren't just polite words. They're psychological softeners. They turn a demand into a request. It signals that you respect their property and their autonomy.
Let's talk about the hardest part of reception work, the delay. The doctor's running late. The patient is staring at the clock. The natural instinct when someone complains is to be defensive. The mistake? You have to wait. The doctor is busy.
This is where practices lose patience. This tells them their time is less valuable than yours. It creates resentment. The doctor is busy is an excuse, not a reason.
It sounds dismissive, but we are busy. How do we communicate that professionally?
The fix. We're running about 15 minutes behind schedule. We appreciate your patience.
There are two distinct things happening there.
Correct. First, you give a specific number, 15 minutes. Uncertainty breeds anxiety. Specificity breeds confidence. Even if it's 20 minutes, the number anchors them. Second, you don't apologize for being busy. You acknowledge their contribution, their patience. You maintain control without surrendering authority.
That's brilliant. Acknowledging their patience rather than just saying sorry completely changes the power dynamic. Last one for reception. Privacy. You need to verify an address. The mistake is shouting across the desk. Is your address still 123 Main Street?
You've just violated their privacy shield. The whole waiting room now knows where they live.
The fix?
Lower your voice. Lean in. Could you please confirm your details on this screen? Silence is a tool. Use it. Let their eyes do the work so your voice doesn't betray their privacy.
All right, let's move to the exam room. The door closes, the latch clicks. The patient is sitting on the paper, feeling vulnerable.
This is the critical moment. Your first sentence establishes everything: the hierarchy, the trust, the flow.
I hear this all the time, especially from specialists who are rushing between patients. The mistake, what is the problem? Or why are you here?
This frames the patient as a problem to be solved. It sounds mechanical. It suggests you're a technician examining a broken machine. What is the problem implies there's a malfunction, not a human experience.
It lacks humanity. What's the professional alternative?
The fix. What brings you in today? Or how can I help you today?
It's open-ended.
It invites a narrative. It allows the patient to tell their story. Research shows if you let them speak for 60 seconds uninterrupted, you'll get the diagnosis 80% of the time. But if you interrupt after 18 seconds, which is the average, you miss critical information.
Now, history taking. This is where I see non-native English speakers struggle the most, and unfortunately, patients judge them for it. The mistake, since when you have this pain?
That's a direct translation from many languages. It's incorrect English structure. Here's the harsh reality. When a patient hears broken grammar, they unconsciously question your medical training. If you can't structure a sentence, can you structure a treatment plan?
That's brutal, but it's the reality of unconscious bias. What's the polished version?
The fix. How long have you been experiencing this? Or when did these symptoms first start?
I love the word experiencing.
It's a professional verb. It creates slight distance between the patient and their pain, allowing them to observe it more objectively. It also sounds more sophisticated than having.
Okay, next part of history. The patient says it hurts. I want to know where. Where? Show me.
Too aggressive, too abrupt. You're demanding they perform for you.
How do we guide them better?
The fix. Could you describe where you feel the discomfort? Or can you point to where it hurts? Better yet, is it sharp, dull, or throbbing?
You provide the vocabulary, you guide them. You're the expert leading the witness. By offering options, sharp, dull, throbbing, you demonstrate that you understand the landscape of pain. You're not making them search for words. Now we get to the most sensitive part, the physical exam. Words are safe, but touch requires explicit consent.
If you don't pave the road with words first, the touch will feel invasive, even if it's medically necessary.
The most awkward moment is telling them to undress. The mistake, take off your shirt or remove your clothes.
Those are imperatives. Cold. It strips them of dignity before they strip off their clothes. It makes them feel like a specimen, not a person.
How do we maintain their dignity?
The fix. I'm going to need you to remove your shirt for the examination. Here's a gown for you to change into.
I'm going to need you to... Why that specific phrase?
It's a soft command. It explains the medical necessity without sounding like an order, and immediately you offer a solution, the gown. You provide coverage before you ask for exposure. That sequence matters.
Then comes positioning, getting them on the exam table. The mistake, get on the table. I've actually heard this said to elderly patients. It sounds like you're talking to a pet.
It's disrespectful, and with elderly patients, it's also unsafe. The fix. Please have a seat on the table, or could you lie back for me, please?
For me.
Yes, this is a subtle psychological framing. It makes their compliance feel like cooperation, a favor they're doing for you, rather than obedience to authority. It fosters partnership.
Now, the warning. You're about to palpate a tender abdomen or use a cold stethoscope. The mistake, doing it without speaking.
Silence here is a mistake. If you touch a cold stethoscope to a warm chest without warning, the body flinches, the muscles tense, the exam fails because you can no longer feel what's underneath the tension.
You have to narrate your actions.
Precisely. The fix. I'm going to press on your stomach now. Let me know if you feel any discomfort. Or, this might feel a bit cold. You predict the immediate future. When that future happens exactly as you said, your credibility grows.
And when they're clearly in pain, the patient winces during palpation. The mistake, relax, it's okay.
Never tell someone in pain to relax. It's a command they cannot physically follow. And saying it's okay when they're hurting is dismissive. It denies their reality.
So what do we say instead?
The fix. I know this is uncomfortable. I'll be as quick and as gentle as possible. Validation, then a promise of brevity. You acknowledge that the pain exists and you commit to ending it quickly.
Closing the loop. You're rushing to the next patient. Anything else?
This signals you're done. You're already mentally in the next room. Your body language usually matches. You're turned toward the door, maybe even with your hand on the handle. It says, please don't say anything else.
So, the fix.
What questions do you have for me? Or what else can I clarify for you before you go?
What questions, not if.
Exactly. It shifts the assumption. It's not a yes-no gate. It's an open door. It gives them explicit permission to speak. It signals that even though you're busy, you are still present for them.
And finally, the goodbye. Bye. It's too casual. We're not friends who just had coffee.
The fix? Take care, and please call us if your symptoms change. It's professional warmth with a safety net. You aren't just ending the visit, you're establishing a plan for the future.
We've covered a lot today. From that first, are we seeing you today, to that final safety net at the door.
You might think your job is simply to diagnose and treat disease, but that's only half the truth. Your real job, Marcus, is to manage fear and uncertainty.
And using these scripts, these mistake fixers, it's not just about being polite or politically correct.
Not at all. When you replace a blunt command with a professional request, you're not just being nice. You're constructing an environment of competence. Patients judge you in seconds. They watch your eyes, they listen to your tone, but the real test is how they feel when they leave that room.
If they leave confused, we failed. If they leave feeling understood and empowered, we've succeeded.
To help with this, I've compiled these phrases into a downloadable guide. It's available for free. You'll find the link in the description and comments section below.
Thanks for listening. Don't just speak. Control the clinical signals everyone else misses.